Our next speaker is going to be Dominique Deroubet. He's at the intersection of a lot of the themes that we're exploring today because he's the Director Général I should say, des Hospices Civils de Lyon, which is the second largest university hospital system in France, with an annual budget of 1.7 billion euros and 23,000 employees. He's got a deep understanding of the evolution of healthcare in France, having spent more than 30 years working at senior levels of administration throughout the country. He will speak in French, so take your headphones if you need them. You can sit down.
Good afternoon, ladies and gentlemen. Thank you very much for giving me the floor. So I think one of the first subjects that you wanted me to talk about this afternoon concerned the evolution in the French health system and the role played by the main stakeholders, and how we appreciated this role and how we appreciated this evolution. Now, this is a subject which is enormous, and we can't really address this subject in a few minutes, but nonetheless, I'd just like to try and stress the main challenges that we have in France, and I'd like to try and highlight the big issues that we have, and then from then on, I'd like to try and suggest some objectives that we could be pursuing. Now, as far as the challenges are concerned, there are many challenges ahead of us. Now, I see at least three big challenges, which are bigger than the others. The evolution of health expenditure in France. You know that for a very long time in France, we estimated that there was about 10% of our GDP which was bearable from a financial point of view, and it was bearable for our national community. But this being said, for all our expenditure, funding social protection has in fact largely exceeded this threshold over the last few years, and now this is becoming an increasing burden for society, and this is becoming increasingly incompatible with the major financial and economic balances in our country, and even could completely unsettle our country and could even challenge the continuity or the sustainability of our health system, or the idea that we have of social welfare and social security. So that's the first challenge for our country. Our country absolutely has to control its health expenditure more in future. And the second challenge that we have is slightly contradictory with the first one, but nonetheless this is a real challenge, and we talked about this a few minutes ago, and this is the challenge of the aging population that we have. So you know that we're going to see more and more aging over the next few years, and this is an important factor in the exponential increase in our health expenditure. And the third challenge that we have, which is a big challenge for us as well, is the persistence, despite the growth in health expenditure, so the persistence of a certain level of inequality with regard to healthcare. So not only unequal access to healthcare, and this is obviously the big problem of a social security system in France now. Nonetheless, our country is rather well placed compared to other countries in the field of social security, but we know there are some disparities, and with the development of unemployment and precariousness, this is starting to lead to certain difficulties in access to health care for certain categories of the population. Also, we have territorial differences which are coming to the fore more and more. The distribution of medical resources in cities and primary care, but not only a problem of primary care, particularly due to the fact that certain hospital structures are entering into difficulties and are not able to guarantee certain services such as childbirth, A&E, etc., etc. And then another inequality is unequal access to innovation, technological innovation, and also treatments. We need technical platforms for certain treatments, and this means that we have to have a certain level of concentration of services in certain areas. So these are three challenges that we have, and these three challenges in turn define certain problems that we have, and I think there are three main problems. The first problem that we have is the adaptation of our medical resources and the distribution of our medical resources. Now, this might be stating the obvious, but nonetheless, without doctors we can't treat people, so that might seem clear, but nonetheless, in this field, there are many constraints that we have to deal with. First of all, we have the consequences of what we call the numerus clausus that we've had in France for many, many years, where we have a fixed number of doctors who are trained, and in certain medical disciplines, we are sadly lacking a lot of doctors, and also the role of the renewal of generations or aging populations, and the fact that we tend to give priority to certain medical specialities and not necessarily general practice, but also the new balance between professional life and private life, and which makes it unattractive for certain people to want to become general practitioners. So we might well, irrespective of the theories we have, if we're not able to manage medical demographics and medical resources better, then obviously this poses real problems in the field. Another problem that we have, which we really have to bear in mind, is the status of medical progress. Medical progress is part of the DNA of medicine. I've never met a political party or any pressure group that thinks that we will commit to freezing progress because of financial or economic issues. Medical progress will continue, and obviously medical progress will lead to certain extra expenditure. It would be difficult to claim the opposite. And another problem we have is research and innovation in medicine, and more particularly the dissemination of medical research and innovation. By definition, this research and innovation goes beyond the pure limits of the medical field. It includes pharma companies, care structures, medical teams, and naturally leads to economic development prospects for our country, but this goes beyond the sole medical sphere and national sphere. Now, in view of these challenges and problems, we are seeing certain big objectives coming to the fore, certain objectives that we're pursuing in our health system. Now, these objectives are not new, quite clearly, and at the end of the day, we are striving to reconcile the funding capacity of our country with a guarantee that we'll be able to have an adequate medical and care system, which is a quality system, naturally. And on this theme, there's a lot to be said about this theme, but simply put, we can see that even if it's very difficult, we can see whether consciously or subconsciously, our country, step by step, has to move from a structure-based logic to a more territorial-based logic, and then a patient-based logic. So the structure-based logic is the current logic which dominates the market, and this is based on economic deficiency in care. So basically decreasing charges and increasing activity, because in the French health system it's activity which guarantees the remuneration of health establishments or medical acts and gestures. So in this field a lot of things have been done, but this is my personal opinion now. I think we've arrived at the point where this policy is limited. So this policy is even becoming counterproductive, because it's leading to competition between the different health care establishments to try and get more and more patients. Now, the territorial-based logic is starting to appear now. Not clearly enough, in my opinion, but this is based, at the end of the day, on a simple principle. We can't do everything everywhere, and obviously you can't do everything well everywhere. This logic necessarily means that we have to change the split of our activities. We have to graduate the territorial system, health system, and this logic is necessarily based on the question of whether certain establishments should be specialized or not, and this is a very topical debate right now. It means we have to think about new territorial spaces which might in future, I don't know, give more weight to proximity activities, or finding the right balance between certain health care and proximity committee activities, so this is nothing new, but this territorial approach is not really developing very easily because of the fact that health institutions want to guard their own territory. And then we have the care policies, the medical strategies, so we have to adapt these policies not necessarily to the interests of the health establishments and teams, but more towards the health path of the patients. So we have to be more patient-centric, and this is going to lead to a major change in paradigm, which has to be encouraged, obviously, but I don't think we have the basic tools in place today to be able to do this. I don't think we have the methodology, and I don't think we have the funding to do this either. So in addition to these thoughts, just to finish on this theme, I would say that, personally speaking, I'm rather convinced that the evolution in our organization is not going to suffice to overcome all of the challenges we have ahead of us, the challenges I mentioned earlier on. And therefore, we're going to have to think about new trade-offs between mandatory insurance, the resources that we get from mutual funds, but also probably the intervention of the private individuals themselves to fund their own care and to fund our health system. So that's basically a few thoughts that I wanted to give you to start off with.
Dominic. I'm going to not ask any questions now because we're going to call to the floor Finn Christensen from Denmark. He's going to talk to us about health technology assessment, and there might be an opportunity maybe to come back as well. This is becoming an increasingly important tool for determining the clinical and economic value of new drugs. And Finn is head of the coordinating secretariat of the European Network for Health Technology Assessment, UNETA, I think it's known as in common parlance. It's a pan-European network of health technology assessment agencies. It's established to promote cooperation and knowledge sharing among European health technology assessment organizations. It's kind of interesting, actually, that I think the sort of EU sort of HTA strategy is that regulation is global, but decisions are local. But at the same time, there's very interesting coordinating activity going on at EC level around health technology assessment. I think Finn can actually enlighten us an awful lot about what's happening here. It's quite interesting.
Thank you very much for this opportunity. I know that we need to be finished in time, and I'll do what I can to support the facilitator in that. So I'll be brief. Yes, indeed, this is a European network, and this is actually a global conference. But it's actually, as you already alluded to, it's quite a difficult area to work on because the national systems are different, the prosperity of countries differ, etc. So how can you do anything sensible in the area of getting the evidence sorted out and structured in the best possible way with others? We thought we should start in Europe. In this network, we have all the national and regional institutions that have been designated by the member states of the EU to participate in the network. That means that it's typically institutions that are indeed informing either reimbursement or healthcare decisions at national or regional level. For example, from this country, it's the Autorité de Santé, HAS. From Germany, it's EQUIC, and from UK, it's NICE, and I could go on. It is really those that have these roles, and our exercise is trying to do as much in a standardized way and in a way that we can share and use together, because there's a hell of a lot of duplication of work in this area, looking at new technologies, etc. And by the way, when we talk about technologies, it is both interventions and diagnostics. It can be devices, and in this area, we are, like anybody else, struggling with new challenges. Particularly because of the stratified approach, the build-up of evidence that is different from the evidence behind the so-called blockbusters, and also some of the challenges that in the area of devices and in the area of biologicals, we are often dealing with small and medium-sized companies rather than the big usual companies that we deal with when it's drugs. takes a little time to load. So the collaboration at this time in Europe is actually that it has a kind of political dimension, because there is a legislation. It's voluntary for the member states to implement the details about HTA, but there is a legislation on patient rights, and in that there is also the support for a network cooperation in technology assessment. And so the blue one here, a pivot, is the political, the policy level, and UNETA is the scientific and technical level. And we have been working our way over so-called joint actions supported by the EU and the member states through developing tools and increasingly applying the tools to inform the national systems. So the idea is that you have your national processes. They need to be targeted, they need to be localized to the decision maker in Bavaria or the decision maker in France. But again, very much it's building on the same core evidence. How can we handle that so that we can speed up the processes and get the effective technologies implemented on broad scale, if that is relevant, across Europe? We have a model that we are applying, and it's reflecting that there are several dimensions of value. There is, of course, the clinical value. We're used to that. That is, what can we see in terms of the patient outcomes that are showing a beneficial effect and efficacy or effectiveness of the intervention. But there are actually other elements of value. People would then immediately jump to thinking about economic value, going to considerations about prices. Yes, indeed, these are important dimensions in the decision process. But it actually goes through considerations also about the organizational consequences of the new technology. Now, we heard a piece of advice in this session that small companies should not sort of flag that what they were coming with would make big changes in the health system. Well, I do understand the point, but in fact, sometimes you can see real gains in the system from a new intervention. Just think about the surgeons that used to remove nerves from the stomach of patients if they had ulcer, and now we see that drugs are more or less have just done away with duodenal ulcer. So small things can actually make a big difference, and this broad approach, these dimensions of value, can actually facilitate that these things come forward. The way that we have been evolving is that we started to concentrate on developing joint methods for rapid relative effectiveness assessment of new drugs and new devices. We also do broader HTAs, but we're also into early scientific advice, that is advising on how to do the development of evidence. That is actually what the decision makers will be asking for further down the line, and also in the area of additional data collection. And with the regulators, we are acknowledging that the whole paradigm of assessment may be changing these years as the new approaches of personalized medicine, stratified medicine is coming more into reality. And that's where we are working on finding ways to adaptively assess evidence as more evidence is developed on new particular biologicals, new drugs for very small indications, at least in the starting. This is very, very difficult, and some parties around us, like the payers, will be very concerned if there are shifts from current paradigms that are so well established and have worked so well when it comes to blockbuster drugs. But we need to go this way also to make our activity still relevant for the decision maker. I think I'd stop here.
Yeah. Thank you very much, Finn. Just one question in particular that I'd like to ask you. Traditionally, industry has been a little bit resistant towards HTA, especially the sort of American-based pharma industry. Now they're realizing it's kind of inevitable, but I think they still want to have some sort of say in how this is being rolled out. maybe at an intellectual level, I'm not quite sure what kind of influence they can bring to bear on European national healthcare systems. What's your take in terms of how the industry is interacting with your body, for example?
Well, we involved industry with the other stakeholders in a stakeholder forum since years, and the industry, particularly the pharmaceutical industry, is the most voluminous, the most heard.
Yeah.
And they have, of course, a lot of concerns, but they actually also want to see efficiencies in the processes of bringing a drug after licensing to the actual use. Mm-hmm. And currently they are sort of knocking at 28 doors in Europe, yeah. And they would actually want also to see some kind of improvement of that situation. So it's very difficult because we could not make one central European piece of advice that could go directly into any decision maker across Europe. But we can still work on the core information that can be shared.
Yeah. So just speed up the process and speed up their access to markets.
Yeah.
Yeah, which is a no-brainer.